Okay, good morning everyone. We've got a big session. When I have practice nurses together, I really try and get as much info as I can. So the first thing I actually want to do is find out what you want out of this session. So I'm actually going to write things on the white piece of paper here. And if you could just yell out what you're hoping to learn, please. Just yell it out. Quickly. New products, so products, yep. What else?
Leg ulcers.
Yep. What else?
And proud flesh.
Hypergranulation. Yep. What else? Say again? Oh, okay, well that's kind of in there, yeah. So debriding, sloughing, yep. Ooh, not in there, but that's good. Really.
Future in wound care.
Okay.
Cost.
What's that?
Cost.
Cost. Oh, that's in there.
Latest in burns.
That's not in there. So this is why, I mean, I can't put everything in, and I knew that this would be the main thing. So we focus on that, and then I chucked in last night a few more things, and I did not put burns in. But we can talk, you know, we go through these things talking. What else? It's mentioned. So infection mentioned. Okay, that's a good start, all right. So the two I haven't really got is Borrelia and burns, and future, well, I'd kind of do that. Okay, good, let's go. Click on my name. Could have done that, couldn't I? Righto. All right. Turn it on. Let's go. All right, that's me. So this is not a scientific presentation, but rather a practical insight into what is my clinical practice within a large general practice in Melbourne. So I am a practice nurse. I am not registered, but it's because I'm also a vascular nurse registered and a Wounds Australia registered and a something else registered, so I've got too many others. One day when I finally only do practice nursing, I'll register, all right? I have no conflict of interest to declare and prefer to consider I work with companies to develop a structured approach to managing and preventing wounds. So there are times when I will go, I love this product. And look, if you're a company rep in the room, tough, that's what it is. I love that product. I'm not being paid today for my time in delivering this presentation. However, all my expenses to be here are covered by the organising committee, for which I thank them immensely. So my current practice is short of me today. They're not happy. You know that not happy Jan statement? They're not. Okay, so this is slide number 1. You have these slides. You have the first 60 or 90 slides of the presentation because I've got to set the basis for you. So have a look at your PowerPoint and put an asterisk next to it. This is the most important thing you can ever be taught about wound management. Okay, and for those of you who came for dressings, see how it's dot point number 3? Because if you don't do it in this structured approach, you're probably going to struggle. Because dressings aren't everything, okay? So I won't read it off the slide, just know that that is the overarching principles of wound management. So actually making the diagnosis is the responsibility of the doctor, but it doesn't stop us from gathering information and feeding that to aid that process, because patients talk to us a lot more sometimes than they do to their GP. So we're very good at gathering information and putting it all together like a jigsaw puzzle, and now it starts to marry up. So feed any little bit of information you get to the doctor that you think may be relevant to a diagnosis. The most common diagnosis, and I'm happy to have this discussed, I see in general practice are lacerations and abrasions, skin tears, boils, carbuncles and infected sebaceous cysts, dehisced surgical wounds, ulceration of lower legs, burns, foot wounds. So that's not on our piece of paper, and I thought you might ask for that, but I will go to a little bit on foot wounds and skin lesions. Anything I've missed? Okay, so that's what my general practice looks like. I get everybody else's rubbish though. I am a referral centre for GPs in Victoria, so I do get lots of really unusual stuff. So this workshop is to deal more with dressing selection. However, before you can contemplate that, you have to understand the physiology of wound healing and factors influencing healing. As you will have seen, dressing selection is principle number 3. So we begin with the formation of a blood clot and work through the stages of chemotaxis, migration of neutrophils, macrophages and fibroblasts, angiogenesis and the formation of provisional matrix, then the synthesis of collagen, the assembly of collagen matrix, and the migration and proliferation of keratinocytes, and finally wound closure. And you all knew that, didn't you? Absolutely. Look, the reason I put it in is because there are lots of words, all right, and there are lots of terms, and you go, oh shit, what's she talking about? They're filming this. But you kind of do know it. So that language that I just gave you fits into this picture. So we all start with bleeding. A wound will start with bleeding, and that bleeding triggers the brain. It recognises it's got a wound, and so now we start the process and send down certain types of cells to do some work, and then when those cells have done the work, we move to the next phase. So inflammation is the first phase. The next phase is the destruction of dead tissue and cleaning. That then moves us into growing new tissue, and then we grow skin, and then the whole area matures. And this whole process takes 365 plus days. However, that doesn't mean we let you have a wound open without skin for 365 days. We give you 1 month to make a significant difference to a wound. So much so that you could actually say to the patient, you're doing well, I think you're going to be healed next week or 2 more weeks. You know, you need to be seeing the end in sight. And if not, that's when you start to problem solve. All right? So you have to really look at tissue and say, what is this wound trying to do? And now how can I help it achieve that? So it is very complex when you read some of the pathophysiology of wound healing and what's coming out in the new science. It's extremely complex, but we don't have the microscope at the bedside or in our clinic to put over the wound and say, oh, there's not enough TGF-beta in there, we'll just get some and add it. We have to look clinically at the wound itself and the exudate. All right, so please, when you take a dressing down and start to do your work, keep the dressing there until your doctor's had a look, because we look at dressings. Or if you are asking your patient to have a shower before they come to clinic, they have to bring their dressings in a plastic bag, and you have to look at them. You need to see, did the dressing do what you wanted it to do? All right? The question of why does an acute wound become chronic, given all wounds commence as acute injuries, is the question that we ask. Because there are wounds that do go on to heal, almost despite what we do. I always use the example of a 6-year-old coming home from school, falls over, grazes his knee, the serum starts to drip down, so by the time he's reached home there's crusted serum dripping down his leg, goes and plays in the sand pit, gets sand in it, the dog licks it, then he sits there and picks it, you know, picks his nose, picks his wound, and it still heals. Yes? So why? So there are a lot of factors that influence healing. This started as a skin tear. Well, clearly something is going wrong. This was a sewn up abdomen. Clearly something's going wrong. So in a textbook version, you could see this type of schematic representation of a stalled wound. So researchers believe that the inflammatory phase of healing continues uncontrolled, so that the normal processes that should engage fail to, and therefore wound healing fails, right? That's what they believe. Now that makes sense, doesn't it? I mean, if you put the key in the engine and the car doesn't turn over, then clearly there's something wrong with the starter motor, the start. So that's what they're looking at here. Something's wrong with the start of wound healing. So they're all focusing on that inflammatory phase. And I think that's probably where our future is for those of you who are really trying to keep up with disease processes, etc. Everybody is looking at inflammation. Cardiologists are looking at inflammation in the heart. Respiratory people are looking at inflammation in the lungs. We're looking at inflammation in the wound, all right? And I think that one day we will, in general practice, be asking a patient about their bowels when they have a wound. Relevance, your gut flora is extremely important for your immune system. You know this now because everybody's talking about probiotics. Okay, there seems to be some quite significant relevance. I did ask at a conference once, many years ago. I got laughed at when I stood up in front of 4,000 people, and I asked, how does a patient who had a leg ulcer that was swabbed and had no bacteria in it and then was completely wrapped up for a week and was continent, so no issues, when you take the dressing down a week later and swab it, it's got E. coli in it? Where did that E. coli come from? You all will swab at some stage and get E. coli if you swab. We'll talk about that later. All right, so where did the E. coli come from? So it got out of the gut and into the interstitial fluid, and it travelled down to your part of weakness, which was the wound. So that's where the future, I think, is lying, is that we're looking at inflammation, and if we can calm inflammation down, we may be able to make a shift in wounds. The slide here first talks about there's no trigger of acute damage. So in other words, I injured myself, but my brain didn't get a message that I'd injured myself. So what disease might I have? Say again? Okay, so why would the diabetes? Why would the diabetes influence my brain getting a message that I've got a wound? Okay, so there may not have been a nerve issue, yes, a feeding of the nerve to the brain, yep. The most common is you've already got an immune disorder, all right? Or you're taking anti-immune drugs. So you're taking anti-inflammatories. You're calming it all down. Well, the body wants to know you got a wound, all right? So no trigger at all. The next is exaggerated inflammation. So what kind of people would get over-inflamed wounds? Those who already have autoimmune disorders such as diverticulitis, rheumatoid arthritis, the itises I call it. Because when they get something wrong, they're going to express it even higher because that's their disease. Pain is significant. So there are papers I'll show you soon that do highlight that just fixing pain will often go on to help wound healing. And to be perfectly honest, it's not on the slide, but I had a patient in my own practice. We put on antidepressants and her wound, we did not change her wound regime at all, and her wound went on to heal. So, and there are papers on that. So depression will delay healing. The next one says increased MMPs and decreased TIMPs. So MMPs are matrix metalloproteases and TIMPs are tissue inhibitors of metalloproteases. Well, there we don't know. I guess if you had a lot of exudate, then your wound is not in balance. And we're trying to get the wound in balance, but we don't have a microscope to put over the wound and see that the MMPs and TIMPs are out of balance. However, there is a product called Wound Check. Expensive, but Wound Check. It's about $90. We've asked for a long time, could we please have a swab stick that we could run over the wound and it would change colour? I asked for this 25 years ago, and if it went blue, I went and got the blue dressing off the shelf, and if it went pink, I went and got the pink dressing off the shelf. That's what I asked for, a dipstick. Well, there is this product. So you swab it, you drop it down into a solution, the solution changes colour, and based on that colour it will tell you whether you have an imbalance in your MMPs and TIMPs. And the solution to it then is you buy that company's product that will rebalance it. Also very expensive. The product is called Promogram, and the check is called Wound Check. You can look those up. They're made by Acility, I think, or Cystogenics. The next is to do with growth factors again. Then senescent fibroblasts. That's a kind of, what are they talking about? Well, you've got cells in the wound, and a bit like this room here. If there was a fire evacuation, we would delegate people to clear the pathway, we'd delegate people to stand and keep the doors open, we'd delegate people to turn the light switches off, you know. So in a wound you have all these cells that are all got specific jobs to do. But if somebody doesn't open the door, then we can't do the rest of the things we want to do. So in wounds, if one group don't continue to do the work properly, then the rest go, I'll just wait. So they're hanging around, they're there. When we actually biopsy them, we've got those cells there, all right, but they're asleep. That's called senescence. So they're there, but they're not active. So we have to get them active, and that's where wound cleaning is the most important task you can do. You've got to get rid of all the sleepy heads and all the non-functioning ones and start again. And that's why in our early days, surgeons were very good at wounds because they took them to theatre, scraped all the rubbish away, recreated a brand new acute wound, and we controlled the rest of it while they were in hospital in bed, yes? So that's why they used to say, oh, you know, we can get them healed and you community nurses can't. Well, all the factors influencing healing are often controlled in a hospital environment. It's a controlled environment. But in a patient's own home, we've got no control. So this senescence and cleaning is probably the best thing that we can do, get rid of the sleepy cells. Increased bioburden or biofilm we'll talk about, loss of moisture control, and altered nitric oxide levels we'll also mention in a moment. So, who knows Heidi? 1. Okay, so this is 2. This is new knowledge for the majority of you then. I believe that when you first start in wound management, you need to take a very structured approach. Many of us who've been doing this for years do this in 20 seconds, all right, because we're so used to doing it. So you must take this structured approach. So you want to know about the history, and it's medical, surgical, pharmacological, social. You want to examine the total body and the wound. You'll do some investigations and make sure those investigations are followed up. You'll then come up with a diagnosis and follow an accepted pathway and set that intervention of planning care and reevaluate it. So with regard to the history, things like diabetes, the person who mentioned that, is quite correct. That is a significant factor in wound healing. Is there diabetes and is it controlled to the levels that we want it to be? Do they have rheumatoid disease? Because there is a close relationship with rheumatoid disease and vasculitis. Or do they have cardiovascular disease, which clearly will tip them over into arterial disease, which means that we may need somebody else to intervene to help us reperfuse that limb. Are they taking immunosuppressants, steroids or antibiotics because they have an influence? Have they had a past history of a DVT or vascular surgery? They're always the questions you will ask. And from that, the wound history, then we will move on to other history. I think I flicked that too fast. Let me go back. Oh no. Apart from the histories previously mentioned, we must not forget to know about the wound itself. So we want to know, how did it start? This is a very important aspect when you're looking at the wound, trying to make the diagnosis. Did it start just as a little raised purple, like a bit of a purpura, a palpable purpura, so a little red dot on your leg, and then it ulcerated? That's probably pretty indicative of vasculitis. Or did it start with a sting? You might have been bitten by an insect. All right? So we need to know, how did it start? Did it start with trauma? Tell us about that trauma, so we can anticipate what possibly happened to the tissue and also what kind of organism might be in the wound. When did it first appear? So how old is it? And what's been done to date? Very relevant. How much pain? Pain is an indicator that this is not a normal wound. All right? So most wounds are uncomfortable. Excessive pain. Ever had those people when you take the dressing off, as soon as the air hits it, they're in excruciating pain, or you just gently wipe and they're, you know, plucking them off the ceiling. That's abnormal pain. All right, so pain's a very good indicator. This is not a normal wound. And if they have had slow to heal wounds, what was done before? Because if they say, oh, I had to go and see a dermatologist or a specialist rheumatologist, or I had to start on cortisone or infliximab or autoimmune drugs, you know, oh, this probably is another one of those type of wounds. So heading you in the right direction. With regard to medication necessary for the treatment of concomitant disease may have adverse effects on the ability of the body to heal. Whilst this is an old slide, many of these are still extremely relevant. So taking anticoagulants is known to delay healing. Antihistamines, some antimicrobials. The one that interested me was the colchicine right down lower, because so many patients keep taking cold gout or colchicine so they don't get gout. So we need to know what medications you're on. I'm not very good at this. I did my medication module and out the head it went. So ask the doctor, are they taking anything that can be delaying healing, or ask the pharmacist, all right? Or you can take a speciality in this. So websites, I give you lots and lots of websites to go to. They're all free, okay? A couple of them will ask you for your email address so that they can send you an update on what they've fed onto the website. They are not intrusive like David Jones or somebody else, Suzanne. All right, these people only send you notices about once a month, and it's a paragraph. So the EWMA stands for the European Wound Management Association, and they put out a document quite a number of years ago now, Hard to Heal Wounds, a Holistic Approach. And in that document was the start of the discussion on depression delaying wound healing. So there's some papers in there that will discuss that. The social aspect also. And then a few years later, Wounds International put out Optimising Wellbeing of People Living with a Wound. A very good holistic document to have a look at, to say there are many things that we can do that will help move this wound along. That's one of the reasons why perhaps wound healing fell into the hands of nurses, is because we were trained holistically, whereas many doctors trained on systems. So the only interest, I always say, an orthopaedic surgeon doesn't need a patient, he just needs x-rays, because that's all he's interested in, all right? So, but we trained on the system. So, you know, commenting on how beautiful they look today, their hair's lovely, nice jewellery, da-da-da-da. They kind of walk in like this and they walk out like this because they feel good. Feeling good is part of healing, being well-being. For me, the other aspect that we need to concentrate on is nutrition, without a doubt. Okay, so it's something you do have to discuss. You will have knowledge of some of your patients, and we all live in different areas. My GP practice borders on two areas. One half on the other side of the road is middle class to upper class, and the behind is government housing. All right, so we get both. So you have to know who's eating well, who's telling lies. They all tell lies. All right, so you'll ask them about their diet, and if you are suspicious that they're just telling you what the new idea says you're supposed to eat, 3 veg, blah, 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 then ask them to keep a food diary for 3 days. So every bit of food they eat, ask them to write it down. Amazingly enough, when they write something down, they're honest. So they will write down everything, but face to face, they tell you fibs. All right, now, the magnitude of the increase of nutrition depends on the number of wounds, the size, depth and severity of the wound, the amount of protein-rich exudate. If you are taking dressings off that are very heavy, full of fluid, that is protein they are losing out of the wound, and that protein must be replaced. Remember, if there's an infection present. So yesterday I saw a resident in aged care and her serum albumin was 23. Now she wants to die, but she's still eating. So it's like, I'm not quite sure, I'm getting mixed messages. I went back in and I said, you can tell me to leave the room, tell me it's none of my business, but I want to know why you don't want an amputation. Because the staff tell me if we amputated your leg, you could be home. You don't really need to be here. You're cognitively well, you're very well, we could teach you how to survive. But she has osteonecrosis of her other leg. That's why this leg has exposed kneecap joint replacement. Big, disgusting wound. But she's not going to heal with a serum albumin of 23. And that's the infections eating her nutrition. Comorbidities such as recent fractures or trauma. So for you, this is just for your information. This was presented in 2017 after reviewing USA and Australia documents. Malnutrition is prevalent in around 40 to 85% of our residential care residents. It's 60% in acute care, which is pretty disgusting. So, you get your patient back from hospital, surgery, you need to engage in a conversation about food. They sadly will also tell you how bad it was in hospital, all right? Then you need to start talking about correcting that. Now, with regard to our general practice setting, about 20 to 60% of our elderly are malnourished. So other factors that can influence the nutrition certainly are confusion and altered levels of alertness. So I have a patient who has lymphedema, and I've been looking after her in general practice for about 4 or 5 years. And a while ago, she just wasn't on the ball. She was a bit off. And even the other girls I work with said, Joan's not herself. So I wrote in the notes for the GP, please check her mental state next time. The GP didn't see that. So the next time I saw the GP, I said, did you see my note in Joan's file? No. And I said, well, we reckon she's going off the page. And sure enough, she's got severe dementia. So, you know, they can, and it's really quite bad. And the sad problem is that the husband's also got it. And so, you know, in these settings, they hold each other up and they answer for each other. And so for us, it's quite hard to really get on board. But as these patients start to change, just reflect on that and say, maybe we need to do an MNA and other tests. So difficulty swallowing, well, the government is finally starting to speak about that, and I'll show you a picture in a minute. Individual food preferences and lacks of manual dexterity. So, you know, these teeth is a big issue right now in our aged population because government stopped funding dental health care for about 20 years. And encouraged everybody to hold on to their teeth. So these old dears have held on to their teeth but with no dental support, and so now they've got rotting teeth. Well, you can't eat well when your teeth and your mouth are sore. You can't eat well when you've got pain. The eating environment does influence. So the worst person in our environment is a single elderly male. They're the worst. They're going to have everything, chronic disease, etc. The packaging of food, you know, these poor arthritic hands trying to get that butter open in an acute care facility. Or how many of you have actually fought with the cornflakes packet in your motel rooms? You know, it's like, oh, for crying out loud. So there's a lot of things that influence our nutritional intake, and we need to take that on board, and we need to start to have discussions. So I say to my guys sometimes, you know, the pub up the road's got a seniors lunch for $9.95, 3 courses. So look around you and try and encourage them, because the social environment for eating is very, very important. Eating alone is not good. You've all done it. Wine, cheese, bickies instead of dinner. You've all done it. So, what do you need to know? All right. Oh, was that last night's dinner, was it? Right. Oh, the chocolate. I forgot the chocolate. Oh, yes. Yes, Qantas give you now fantails, and they make your teeth stick together. I was like, oh God, forgotten. But they're smaller. Who got a fantail last night? So small. Anyway, okay, these are the normal values. You need to know the normal values. Obviously, every lab is slightly different. What are the ones that you're interested in? You're interested in the serum albumin. That's the protein. Protein's what gives you oomph in your skin and oomph in your blood vessels. So if you're lacking protein, you're going to have a low blood pressure often, because you've only got water in your arteries, and your tissue has nothing to hold it up, because protein gives you that strength. So protein's vital. Jackie, your job. So I should have started. For those who are, so some of you have done it, please don't get a sore neck. Number one, turn your chairs around. I'm going to stand here for quite a while, all right? Second thing is, we're going to pass out things for you to look at. Once the last person on the table has seen it, can you flick it across to the other table? Jackie's going to try and keep an eye on it, but we're going to do all of this. So it's going to get messy later on. So what I want to show you is these things. So Jackie will start to put them around and I'll talk about them. So see on your handout you have that 1-800 number. So what you should do in this presentation is you should actually put an asterisk next to anything I encourage you to follow up on, and 2 weeks from now you might sit down with the wine and read your PowerPoints. That's when the learning happens, because you reread your notes and you see a little asterisk, and now you've got a to-do list. So you ring that company, it is Nestle, and they are here. And they have these little booklets, all right, and they're free. So you need to get them. The pale blue one, Nutrition and Wound Healing, is going to be revised soon. We've actually got a meeting soon to do this. But that's written more for health professionals. And the dark blue one I wrote a couple of years ago for public. Just a little more lay language, that's all. They're free. I have them in my practice, and any patient that I'm concerned about nutrition, I hand them one of the dark blue books and say, please have a read of this. It's very interesting. Okay? The other thing is the mini nutritional assessment tool is available from the website down in the bottom left-hand corner. How many of you use an MNA? A few. Okay, so that's what you need to do also. It's easy to do, people. It's 5 questions. And that will tell you whether this person is at risk of malnutrition or malnourished, and then you'll follow up. If they're at risk, you'll get a dietitian review. If they're malnourished, you'll start to speak to the doctor, who may then even get a dietitian in, or they may go to have the bloods done and then go to hospital for some other things, investigations. With regard to supplements, that we're told not to supplement them with supplements until they can't eat any more food. So they're meant to go for food first. But when you get older, the capacity is lower, all right? And you can't get that amount of protein that you need into you. And so putting a bit of 2-cal, like you see it on TV now, advertised at night, all of these things are on the telly. So there's some company names and some phone numbers for you. The one that I have used quite a bit, certainly arginate, all right, is very popular in wound healing with very good evidence in pressure injuries. They haven't got any evidence in leg ulceration or other types of wounds because the studies haven't been done. But it stands to reason, pathophysiologically, if it helps a pressure injury heal, it must help other wounds heal. So have a look at the arginate. And then the other product, Empracal Repair, it's an Australian product made with whey, all right, so pure protein powder. It is one of the less expensive protein supplements available. I've already hinted that the patient's perception of their wound will directly relate to their progress. We do know that depressed patients heal more slowly, and motivation is a big factor. The power of the mind and the placebo effect is powerful. So if I said to a patient, this water is the purest water in the world, and they say if you drink 2 litres of this a day, you're going to feel so good, versus this glass of water, pretend, this glass of water, all right? And I just say, look, they say this is really good for you, so you should try it, 2 litres a day. Which one's going to do well? The first one, because I sold it to them, because I really empowered them. And so when they have a belief in something, for example, they come in and say, can I try honey? You go, well, yes, let's talk about it. And that will come up later. So when they show some enthusiasm with something, provided you know something about it, you should encourage it if it's not going to do any more harm. So those shakers that, you know, Dawn Fraser's advertising, those things, any evidence? No, none at all. So I have to say to them, look, there's no evidence for those. However, if you've got the money, they make you feel good. Your legs do feel good after it. I can't guarantee it's going to make your wound healing any faster, but, you know, if you've got the money, go ahead. Then I might recommend something else that I do know has some evidence, which we'll cover later on. All right? This is a big problem. All right, so just, you're bashing your head against a brick wall, but some of you have probably done the training on motivational coaching, you know, trying to get them to change their ways. Smoking 1 cigarette decreases blood supply by 50% for 1 hour. All right. So when I used to be in the army and teaching and looking after soldiers and other defence personnel, I knew they smoked, so I would get a Doppler and I would put the Doppler on their wrist, and then I would put it down on their foot, all right, and go. I'd say, can you hear the difference between up there and down there? And they'd say yes, and I'd say, that's because your arteries were already blocking off. Book in for my clinic in 2020. All right, so that if you have a handheld Doppler in your practice, that's often really good to put on the wrist and then put down on the foot and let them hear the difference because they're already clogging off their arteries. Excessive alcohol, we don't know why, but that is sort of related. We think it's just because the alcohol fills you up with the calories, etc., and then you don't want to eat. But we have no hard evidence why alcohol is associated with malnutrition until you get liver failure. All right, now, debris in the wound. So dry tissues, scabs, excess slough impairs healing and it will impair the epithelial migration and supply of nutrients to the wound. It the debris prevents the formation of granulation tissue, prolongs the inflammatory phase because the body keeps saying, I've got to get rid of this, I've got to get rid of this, I've got to get rid of this. And the cells who are supposed to be building say, well, I wish you'd hurry up. And so they go to sleep, senescence. So this is where you have to clean the wound, okay? And of course, we all have patients who have all sorts of things like grass cuttings, all sorts of things. So you've got to give them a good clean. So let's talk about cleaning. How many of you use the language debriding? Okay. How many of you are allowed to debride in your practices? Good, okay. I think it's wrong that some practices say, oh no, you can't debride and you have to go and do a course. I do believe it's wrong because all registered nurses should be able to debride if you've had good registered nurse training. However, there are some practices that say, no, it's beyond your scope of practice. So make sure that you're covered by your facility. Now, there are a whole lot of words used in debriding, all right? I try and not use the word debriding. I just say I gave the wound a good clean. And by not using the word debriding, I haven't committed myself. So you might change your language a little bit. All right.
I say non-viable tissue jet removed.
Okay, perfect. Very good explanation. All right, so you've all got to get rid of this because that crust is stopping the epithelial cells from starting to march across the tissue. So everybody here happy to get rid of that? Now there is a product called Prontosan and there are a couple of others. If you're using Prontosan 10-minute soak, it really helps to identify what's ready to come off. All right, so we'll talk about it again after, but if you did that, this would start to go white at the very edge, and then you grab this white edge and try and, like the minty wrapper, I always try and get it off in one go. I feel very self-conquered, when I can do it all in one go. And then you're going to wipe off this fibrin. So what's the difference between fibrin and slough? Slough is tenacious. When you describe slough, it's tenacious, so my descriptor, chewing gum in a wound. You grab it and it won't come. Fibrin is like jelly, yellow jelly on the wound. And it is literally just the serum set. So you want to get that off to reveal the beautiful granulation tissue underneath. So you need to give that a good clean. The problem we have in some of the products that are chosen to clean is you then end up with maceration. So your method of cleaning needs to be tailored to the wound type. Remember, we do not want macerated tissue. At all costs, we don't want to see white, soggy edges because that increases the risk of infection, and it also means that the edges of the wound have no support and so they collapse and the wound will get bigger. So the bit that you're really interested in is the infection. So I said nutrition number one is one thing I think we should focus on, and probably cleaning and infection would be our top three. So, who's heard of the wound infection continuum? Okay, so this is it. I'm going to give you the resource to find it in a minute, but this is what they're saying now. So let me see. You've got contaminated wounds, you have colonised wounds, you have locally infected wounds. Now we had big fights over this. For 4 years we fought over this term. It used to be called critical colonisation. So you had colonisation, then you had colonisation that was just bordering on getting out of control. They now call critical colonisation local infection. All right. Then you have spreading infection, and then you have systemic infection. So everybody happy with the continuum? All right, so down here at the lower end, if you just do good cleaning and general any kind of dressing, you don't need antimicrobials. But once you start to get to this stage, you're going to need topical antimicrobials, and as you move up further, systemic and topical. All right? And the reference for that is that. Now that came out in November 2016. It's downloadable. It's about 25 pages long. It's excellent. Very good document to read. So everybody or somebody mentioned biofilms. It's the new jargon. It's been around for about 5 years, you know. So if you go to any wound conference, it'll always be a speaker on biofilms. It's actually boring for most of us now. It's like, come on, can we move on to something else? Flavour of the year, all right? We don't really know the relevance of biofilms yet. Certainly biofilms will be explained in the document for you. My easy way of understanding it is they're a group of cells. So this table here, a group of cells living in the wound, all right? And then they decide, let's all get together and make a sugar-coated coating over the top of it. So a polysaccharide membrane goes over the top, and then it wouldn't matter what dressing you put on top, we're all hiding under here and you can't get us. That's what a biofilm is. Then when they grow too big, so they all have babies and grow, then they will say, one of us needs to move out, this is too small, and so they move to the next and grow another biofilm. That's the simplest way to explain it to you, all right? But you can learn more.
So Jan, excuse me,
Yes.
when you say cleaning, what do you like?
I'm going to cover that soon, all right? And if I don't, remind me, I'm getting old, but I will specifically cover it soon. So the document will say frequent aggressive, the word they're using is debridement. Certainly your language, the removal of non-viable tissue gently is a lovely way to say it. But you have to get rid of the rubbish, right? So we don't want to go back to the old days of 4-hourly saline dressings. We really don't. That's when I trained, and I don't want to go back to that, but there are many methods that can help to get wounds clean. So we will talk about that in a moment. If you do believe there's a biofilm present, then you need long duration of high-dose systemic antibiotics. They are developing selective biocides now. And the future in this area is actually that we will take a specimen of your wound, it will go to a laboratory and it will be genome tested, and then a manufacturer will design an antibiotic specifically for those bacteria in your wound. That is the future. So then you won't develop antibiotic resistance because you're having the antibiotic specifically. Now we're years off that, but that's where they're heading. Genome therapy in wounds. So what does the document say you should think about when you're thinking about biofilms? Well, you need combinations of products. So we may use silver, we may use iodine, we may use honey, and so far PHMB, Prontosan, polyhexamethylene biguanide. They're the ones that have been tested so far, but they are testing more. And also at our conference last year here at this venue, we also had some people speak on natural therapies because we are reverting to our native bush. We have some very good researchers looking at some of the products that our Indigenous population use, all right? But the part of the problem there is the intellectual property of those recipes. So that all has to be dealt with in a very ethical manner. Thank you for passing them on. All right, so investigations to consider in this area then if we're worried about infection or any other investigations in HIDE. So wound swab has a question mark after it because you will learn when you read the document that swabbing chronic wounds is actually not advised. Not at all. Because you're really not doing it well. However, if you must swab a wound, you need to learn the Levine technique. And the Levine technique essentially says that you must clean the wound thoroughly of all debris. Then you clean it again, and then you take your swab over a 1 square centimetre surface area. But it's in the document. You'll get it from there. You can also Google it. If you can't practice the Levine technique, I always say contact the laboratory where you send the pathology specimen to and ask them, do they have a protocol on how to take a wound swab? At least then you're swabbing it according to that laboratory's protocol. All right? And the other thing is, please make sure that the box contains some clinical notes, not just leg ulcer, MCNS. The pathologist needs to know, was this caused when they knocked their leg when they were over on Fraser Island? Or was it caused when a child's bike ran into them. You know, the pathologist wants to know the history of the wound, because then the pathologist will look for something different, not the usual. All right, so make sure the clinical notes are completed, not just the quick MCNS. If you're not doing a swab, the gold standard currently is really to take tissue biopsy. And you take a piece of the wound and you take a piece of the edge. Okay? And then the pathologist will look at what's in the wound and what's in the wound edge and identify the one that's actually causing the problem. I say if we're going to give local anaesthetic in order to do a wound swab, I want 2 specimens taken. I want one taken for histopathology and one for micropathology, because I don't want the patient to have to come back later when we get a negative micro report and say, oh, we've got to take another piece now to check that it's not a skin cancer. So I like to do them both at the same time and save the patient that anguish.
That's separate.
Oh, definitely. So for micropathology, it goes in normal saline, and for histopathology, it goes in formalin. And the one that you put in the jar first is always the micro. If you go to put the specimen into the histo and you accidentally put your forceps a little far down, you've now killed the bugs that might be on the micro specimen. Do you understand that? It's easy, yeah. You will x-ray if it's over a bone, and that will tell you then whether you then need to go on and do a bone scan, although most people now skip the bone scan once they get an x-ray that says inconclusive as to osteomyelitis suggest. Most people now go to an MRI straight away. They skip the bone scan. I would encourage you, how many of you see dehisced Caesar wounds, caesarean sections, or dehisced abdominal wounds? Okay, so what you generally have is you have a small hole leaking tons of stuff, and you put your forceps in it and you can't go very far, you know? It's like, I don't know really where this goes. So you need a sinogram done. The reason for that is what they do is they put a catheter in, blow up the bag and squirt some radio-opaque dye in, and often what you get, the report comes back and says there's a 2 centimetre track at 11 o'clock leading to a 5 centimetre cavity. So no dressing you do out here is going to fix that hole in there. That person needs to go back and have lay open of the wound, sewn up in layers, etc. All right? You can do the handheld Doppler for calculating ankle brachial pressure index. How many of you have Dopplers? Good, well done. Okay, so you can do the ankle brachial pressure index. For those who don't have a Doppler, you can send them off for a Doppler at a vascular lab, and then you might as well do the arterial or the venous, depending on which system you're worried about, scan at the same time. Okay. Now, when you're sending them off for a venous duplex scan, please make sure, so you have to actually say this, please never, are there any doctors in the room? Okay, so you have to make sure that the doctor has written looking for valvular incompetence. Because if they send them off for a venous duplex scan, the poor sonographer assumes you're looking for a DVT. So the report comes back, no DVT present, and you just go, I wasn't looking for a DVT. All right, and then they've got to do it all again. So make sure the doctor writes valvular incompetence is what you're looking for. Now, if you've done all that, for this tummy wound, we're going to come up with a diagnosis, and the diagnosis is very long. The diagnosis is the wound etiology, it's the healing progression against known trajectories, and any contributing factors. So the diagnosis for this man with the abdominal wound is he has an abdominal surgical wound with delayed healing related to inability to manage bacterial overload and malnutrition. Everybody happy with that diagnosis? Longhand diagnosis. But by doing a longhand diagnosis, you now have how you're going to intervene. So we're going to use topical and systemic antimicrobials, we're going to educate the patient, and we're going to include a high protein diet. All right? So that was Heidi. Now there are many factors that influence healing. If you go to textbooks, they will talk about these type of factors. So the intrinsic and the extrinsic. And you, as you learn to do your assessment, will do this very quickly, but in the beginning you might do a little quick checklist to make sure you have inquired about these things and you have considered these things. All right? Any questions on pathophysiology and factors influencing healing? Okay. So making that first decision in product selection, you've got to ask, what is the aim? What am I actually trying to achieve in this wound? So these are some aims. We're going to go back to aims after, but these are some aims. So to maintain current moisture, I don't have to do anything else. I just don't want to dry it out and I don't want to donate. To donate more moisture to the drying or painful tissue without damaging peri-wound, to manage excess moisture while not sucking completely dry and naturally prevent damage to peri-wound, to aid autolytic debridement and or probably provide some antimicrobial cover, or just to provide antimicrobial cover or to provide comfort and protect. Now you may have other aims, all right, but there's some aims to think about. So when you're doing that, you need to start to look at the tissue. We've done the holistic assessment, now we're focusing on the wound. How do you assess the wound? Do you use the time model, which most of you will because it's been pushed heavily by corporate, okay? So most of you will do time. I grew up in CDE days, so it was colour, depth and exudate, very simple, okay? There are a few other things that we will all want to look at. We will want to know if there's any undermining or tracking. You understand those terms and the difference between them? Undermining is you go in and you can feel a shelf around there. Extremely relevant if you're looking for the Barili ulcer, if you have undermining. And tracking is you go in and you follow a track. Okay. You want to know the effects of the previous treatment. Sometimes it's important for me when I'm a referral centre because they may say, oh, I had product X on, and I go, oh, that's a very good product. It didn't make any difference. Oh, I said, well, that's okay. We'll move with something else. But we may go back to that because sometimes people use products inappropriately. They're good products, but it wasn't relevant at that stage of the wound healing, but it's relevant now. So never say to a patient that was the wrong product because you might want to use that one day, all right, on the same patient. And then the other thing in general practice we have to think about is how frequent do we want to do these dressings? Now, there are some, I've spoken at APNA conferences many times before, there are some nurses that will actually put their hand up and say to me, oh, we do daily dressings because the doctor wants the zip. Well, that's going to be caught soon, all right? So overbulking for that is going to get caught. My personal preference in general practice is twice weekly. Unless it's doing really well, then we do weekly. Now, you also have to know the products, what the company says. So if a company says this is a daily dressing, and I just said to you, well, we only want to do it twice a week, what are we going to do? So wherever possible, we teach relatives, loved ones to do daily dressings. And we monitor it twice weekly or weekly, okay? There will be many circumstances where you want to do that. You have a university student who can't come to you every day or whatever. So there are many factors that influence our dressing frequency. The manufacturer's recommendations is one, but then we have the client as well. Some other things you need to think about is the depth of the wound. So what goes in must come out, and it ideally does not break up and make removing difficult. So I'll jump in here and say we do no longer put calcium alginate in cavities, all right, because it breaks. So we choose products like Aquacel, which doesn't break, or Sorbact or Measalt, and we'll talk about them later. And ideally it should be the same size as it went in. You've put sometimes stuffing into a hole and then it's all clumped together and shriveled up and the rest of the wound has got no dressing in contact with it. That might happen, all right? And the final part of my CDE triangle is the Exudate. So this is a brand new document. It's only been out for a month or 2 months. It's called Wound Exudate Effective Assessment and Management. It's based on an older document, it's just been updated. Content is brilliant. So again, that's available from the Wounds International website. Obviously, Exudate's described as minimal, moderate and heavy, but this is extremely subjective, very subjective. So you have to think about the volume and the type of Exudate, and that document is brilliant to read. Parry wound is the next thing that we're interested in. So this dressing is not performing well. It has not managed the exudate, and by not managing the exudate, it's now excoriated the Parry wound. So we're in big trouble. Now, what is Parry wound? It is 4 centimetres from the wound edge all the way round. And the descriptors used often to describe Parry wound are here. All right. So there's still a lot of other factors that will influence dressing product, such as pain. We're not going to put a dressing on if it causes pain. Is there a smell in the wound? Do we need to choose a dressing specifically for malodour? Where is the wound located? Thank goodness nobody asked for pressure injuries, because we don't really see many pressure injuries in general practice, do we? No. We see occasional ones coming out of hospital. My personal experience, and I've been running a clinic in general practice for 19 years now, nearly, something like that, is that when one of my patients comes in with a sore bum or a pressure injury, it's usually the decline. They don't usually last much longer than 3 weeks. They're on the way. All right. The size and the shape available. Obviously, we can't stock everything in general practice, so can we cut some of them? Yes, we can cut some, but some can't be cut, therefore we need specific sizes. But above all, what drives our product selection is cost. Companies know this, so I will say right now, before we get onto the table, I'm so disappointed at Hartman, who are here, because you're going to find out that Zejuvit Plus, which how many people in the room use Zejuvit Plus? Okay, a good half of you, has just tripled in price. So it's a global decision. It's not that poor rep's problem. Don't growl at her or him. I've already had a piece of them. Those of us down in Victoria are writing letters to the head office. It's disgusting, but we won't use it. So I'm trying to find others that are less expensive, and I'll talk about what I'm telling you to look at the moment, but there may be others. We need to try them all now. Okay, so not just one colour tells us whether the wound is improving. They're never one colour wounds, are they? So what you want to document is you want to talk about how much granulation, how much epithelium, slough, etc. And then hopefully in a week's time those parameters have changed, because they're not all one colour. So your documentation charts should say granulation, epithelium, necrotic slough, necrotic eschar, macerated. You know, you need these words in your charts, in your documentation. You can put a little drop box down and then you fill it in. And then you can check the percentages. It's a guesstimation, we're not specific. There are great handheld, pointed at the wound, click the button, and yes, it tells you everything, but they're $10,000. We can't afford those. Now, tissue types. These are the types of tissue, and this is the language to use. There's necrotic eschar, there's necrotic slough, there's granulation tissue, there's hypergranulation tissue, or as the oldies call it, proud flesh, and there's epithelium. Oh, and there's macerated tissue. Okay, everybody happy with those descriptors? So we all use those descriptors in our language, all right? But when I'm talking to the patient, I use the colours. I say, see all that yellow stuff? Well, I've got to get rid of the yellow stuff, or the black stuff's got to grow, or you need to grow better quality beef steak in this wound. We engage the patients with our language all the time, but the word slough, they're frightened of. They don't know what it is. So don't use that with your patient. Use the colours more. So, we're going to break soon for morning tea, and we'll continue on. This is a long presentation, but we'll go through these first, all right? I've got about 4 minutes. 1 minute. 1 minute, okay. So necrotic black eschar like this, the quickest way to get rid of it is to cut it off. If you can't cut it off, then you're probably going to put some cross hatches in it and put a gel or another wet kind of product on top. Okay? So cut off or wet. However, when you see things like this, which we don't generally see in general practice, okay, but if you do know that it's an ischemic wound and it's black and dry, the rules are keep it dry. So this is betadine, okay, and don't worry about killing any living cells because there are none. Whoops, gone the wrong way. Okay, 2 types of slough, dry yellow and wet yellow. Dry, you're probably, if you can't cut it off, you're going to put something moist on it. Wet, you're going to put something on to soak up. And that's the one you might consider an antimicrobial. Why is it so wet? Because the body's trying to break it down and there may be bugs there. Yes? But there are other yellow tissues in the body. That's why they don't allow us to use colours when we're talking interprofessionally, because you can have tendon, bone, subcutaneous tissue, and they all require specific care to maintain them as viable. Healthy granulation looks like fillet steak. And if it's really beautiful, healthy granulation, you've got pale pink at the edges. This is not good quality granulation tissue. So we may need to use an antimicrobial. We may need to use something to clean it really well, and we definitely need to protect the Parry wound. Hypergranulation, bubbly, bleeds easily, very friable. You need to identify this as opposed to a skin cancer though. A skin cancer can look like hypergranulation. And the press test is the clue for you. Press on it, it doesn't flatten, feels fibrotic, it's probably a skin cancer. Press it and it flattens, it's probably just proud flesh, hypergranulation. Epithelium, fully healed but very friable. Oh, this could, rub it with a coarse towel and it's gone. Protect, 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 and do not suck dry. The wrinkle test for epithelium. This is red tissue, isn't it? But it's actually got a layer of skin over it. And by putting a forceps on it or a cotton bud, you see these wrinkles? That's got skin on it. It's just not mature skin. So again, protect. The horrible yucky stuff. All right, we need antibiotics probably and topical antimicrobials and exudate management for any of these yucky things. So how do you think about your products? Is it by brand name? Is it by pharmacology? Is it by function? Or do you have some other cute way to think about your products? A lot of you go by brand name. You recognise the brand, all right? If we think about in our practice, we have this. No wonder we're all confused. That's the list of products. And it continues. It's very difficult. If we go by function, look, we've got a big choice. If I only want to protect tissue, if I only want to protect tissue, I've got many products here that the companies say will protect. So how do I decide? So we really want you to develop your own protocols. One slide. Really want you to develop your own protocols, and that's what we're going to do after morning tea. You're going to start to workshop the products, and if you have a look on the table, you have things like these single sheets, and we're going to work our way through these single sheets, and you're going to take it back and start to work on it in your practice, probably more pretty, with pictures and maybe product brand names and things like that. So that's what we're doing after morning tea. Just before we go though, please remember that we do have standards for prevention and wound management at the Wounds Australia website. Okay, the question was, because you're nurses, there's no problem you making a diagnosis. I don't think you should conclusively say, I think the diagnosis is. I think you should ask the doctor and say, I see the patient's got this and this and this. Do you think the diagnosis might be? Your job is to guide the doctor. It is their responsibility to come up with the diagnosis unless you're a nurse practitioner. The question was, where's the stuff we're passing around? It's gone to the very last table near the projector. It's right at the very back. It hasn't come down this side, hasn't it? Okay, all right. So So the bag that it's to go in is right up near that table. If you bring the bag down then, the suitcase, it's going to go, so the suitcase is just near Gary's. The product is on near Gary, up the very back at that last table. So bring it down here then, this is going to be the last table. So it'll go up one side and come down the other side. It will go up one side and it will come down the other side and finish here, yes? Oh, you started there. So it's going to finish in the middle. Okay, it's going to finish in the middle. Okay, well it's, yeah, good. So as long as it all comes back down to the suitcase. Righto, let's go. So now we're ready to focus on products, and then we will conclude with a few case studies, etc. So as I said, how many of you go by brand name? Yeah, okay. There's not a problem going by brand name as long as you know then what function that product holds, all right? If you understand pharmacology of the product, then you're able to understand function better. So that's why all these different terms are used. And of course, many of us do go by company product identification. The issue here then is that many companies only have one colour for all their products. So when you go to the shelf, it's like, what have you pulled off the shelf? You know, the orange one particularly. They're all in an orange box all the way along. So that makes it difficult. So what we have to consider is the aim. We want to consider the tissue type, the exudate type and quantity, whether there is any depth or undermining, or the Parry wound condition. These are probably our most important aspects. I'm not saying they are the only aspects though. So when considering aim, for me, particularly when I work in an aged care facility, is can we heal this or is it non-healable? So healable or healability and non-healable, they are all language that's used around wound aims, okay? So remember, our aims may be these that we've already covered off. This is just in a different language, but it virtually says the same. So let's start with protection products. If we want to protect a tissue, we could use an impregnated gauze or gauze-like product. We could use low or non-adherent pads. We could use polyurethane films or foams, hydrocolloids or acrylic dressings or silicone sheets. So you have a large variety, don't you? For moisture retention, you have films, foams, hydrogels and hydrocolloids or acrylic dressings. For moisture donation, you have saline packs, Lord be if we ever go back to that, or you have Tender Wet, which is now known as HydroClean, or you have hydrogels. For managing tissue in wounds that may be containing bacteria or actually may be necrotic, look at the selection we have. So we have a lot of choice there. Not all are antimicrobial, but many of them will aid autolytic debridement. For moisture management products, we have absorbent and superabsorbent, polyurethane foams, gelling fibres, combinations of products. Now, nurses are naughty people, and we often do things we think, oh, I'll just have a bit of this and a bit of that. Well, come on, people, we are not the pharmacist. We do not know the full chemical pharmacology of the product, so we shouldn't be mixing and matching. So I have seen things like silver and iodine combined. It's like, what on earth? They thought double whammy. You know, like there's some really, I can understand why people do what they do, but you mustn't. So what that combination means is that the company has probably already put a combination together. So an antimicrobial and an absorbent. That's probably what that means more so. And then there's the topical negative wound pressure therapy devices. Okay, so let's talk about them first. They are at the end, but let's talk about them now. How many of you do recommend them in general practice? How many of you have used them in general practice? Okay, a couple, all right. And that's the truth. The truth is that I think we should all know about them. We should all know that they're available and know when possibly they should be considered. But due to cost and getting them covered, they generally come out of hospital with them, and hospital then continues to do the dressings in hospital in the home program. All right, so they are good. There are large ones and there are small portable ones, and they are very good in some wounds, without a doubt, but you've got to weigh all those factors up. So skin protection products, we can use film barrier wipes, we can use good quality moisturisers will protect skin, or we can use specific barrier creams. And lastly, in categorising them in this function, we need to think about what the evidence is out there. And so in the cleaning phase, iodosorb has great evidence for cleaning, debriding necrotic wounds because it stimulates macrophages. The proliferative phase, hydrocolloids can be used, although I'll be canning them in a minute and saying we hardly ever use them, but there is evidence that they stimulate granulation tissue. But the problem there is they can also cause hypergranulation, so that's where we're careful. And in the epithelialisation stage, there is evidence that zinc stimulates epithelial cells. So these are based on papers at a molecular level. For you, considering one element may lead to errors. So you do need to consider multiples of these. Consider the tissue, the exudate, the Parry wound, the pain, the etiology, and thus the prognosis. So if you have someone who has a skin cancer and it's not going to be operated on, then you may not choose a very expensive dressing. You may choose something very, very simple and basic. All right? So we put collectively this all together. Now, for any of you who do use a medical distributor and you've had a look at the medical distributor's handbook, so Independence Australia, who are here, and they often do hand out a handbook for general practice and community settings. There's 111 pages dedicated to wound dressings in this booklet. So it is no wonder that people are confused about what dressing to use, all right? So you need to know what you have and how to use them, and then perhaps learn what you need for some really unusual wounds. And the web is a great place for learning about a specific product. So how many of you bought your list of products you use in your practice? Okay, so some did. All right. So I think that's what we should start with. You have a piece of paper that says the products that you have in your practice. And so I only want you to fill in this column, the first column. What products, and it says product name, so it's how you name it in your practice. Off you go. This is a workshop. Are we ready, do you think? Yep. Okay. All right, now the other pieces of paper you have are one based on tissue in the wound and one based on aim. So take up the one that says based on aim. And you will see a list of products in front of you. I'm ready now. So I think I don't need two of those. There's one they can open them to start wherever you want. Okay. Obviously, I do not have all the products here to show you. I have some, and they're going to come around, and you're welcome to open them and to rub your fingers together on them. You're welcome to do whatever you want with them. Just make sure they move from that table to that table, and they'll finish at this table here, all right? So do you recognise something on the screen that you have? So now you'll write down on, if you haven't already put it on your facility list, you'll write it on your facility list. So if you've got it on your facility list, you can just tick it off, because we're going to ask you, did I cover everything at the end? So you can just tick it off. So what is it? Well, it's a fibre fabric impregnated with Vaseline or triglycerides or carboxymethylcellulose or silicone. So they're not all the same. So what have you got? Vaseline, silicone, carboxymethylcellulose or triglycerides? Do you know? Do you know what your mesh contains? Because that's important. All right? The Vaseline or other substance is meant to act as a layer between the tissue and the fabric, maintaining moisture. So the very old brands of these actually made the wounds too wet. But the newer brands, the newer types coming out, manage that better. Most can be applied to the wound and the peri-wound. However, if maceration does occur, many people trim them to fit the wound to prevent that maceration of the peri-wound. Are there any precautions for any of these? Not really. They can remain in contact with the wound for 7 to 14 days, most of them, but of course some of them are prone to risk the maceration, so you'll be changing them more frequently. And generally this type of dressing is used to with a secondary dressing that's absorbent. So what colour, if you're workshopping, now you've got another page based on tissue in the wound, haven't you? So if you wrote under the product heading, impregnated mesh dressings, then go along and what colour tissue or type of tissue, I've actually got type here, what type of tissue would you use this product as a primary dressing? Yell it out. Yeah, so healthy granulation. You could, it will protect the granulation, stop the secondary dressing sticking. And you might use it on epithelium. So it's the first one and the second probably as a primary dressing. Okay? Everybody happy? All right, next group. Here. I haven't got many of these, Jackie. I haven't got many of those. Next group are your low adherent or non-adherent pads. Now, to be perfectly honest, we tried many years ago to get these labelled as low adherent because so many of us were told they're non-adherent and that was not true. Your melalin will stick. Okay, so we wanted them reclassified, but we were unsuccessful. So hence why I've put low slash, why I put none slash low. So pick your type and then make sure you've got it on your facility list. And now we'll see how to use it. So it is a telfa-like fabric with cotton wool and cellulose toilet paper. The interface fabric allows small particles of water or thin exudate to penetrate and be absorbed into the cotton wool and cellulose. So it's used mainly as a primary or secondary dressing for light exuding wounds. There are no contraindications to using it. When it's used as a primary dressing, it is due to be changed daily. When primary dressing is due, so you change it when the primary dressing is due, or twice weekly to weekly, depending on the tissue below. It may be further, so I've got some here. 1, 2, 3, 4, 5. Don't think that's got a pad in it. And that one. They're all got pads. It may actually be covered with more padding, or it may actually have a film put on top, or a polyacrylate tape. So like Fixamol, MeFix, Curafix, Omnifix. So some companies already make them in that form, don't they? Cutafilm Plus or Mepor Pro. So some companies make them already that way, combined. So now when you look at your product selection based on tissue in the wound, as a primary dressing, where are you going to use this type of product? Possibly the first two would be all you could use it as a primary dressing. Would everyone agree? And if it's sticking when you go to take it off your granulation tissue, next time you're going to think about, do I need something else? Yes? Yep. So as a primary dressing. Okay. All right. Next group are your absorbent pads. Now what I want to say is that a product like Combine, so I'm going to pour a little water on it, just a little, and then squeeze it, and you will find that when I rolled over in bed or leaned on my elbow, it's immediately wicked through. So a product like Combine, we would prefer not to use in general practice for absorbency. But in general practice for padding, yes, we do use this sort of product, right? So you don't need those. So you were all using a product called Exudate Plus. And due to the price, it's been a bit of a diabolical problem. So there are a number here, and I'm going to pass them around. And I'm also going to, I forgot to bring a syringe, so I am going to just put some water and try and put about the same amount of water on each. So the product that I'm currently looking at is Vliwazorb. You know, nothing like getting a complicated name. Exudate was hard enough. Now we're on Vliwazorb. So I'll put some on. You will see it is a lovely interface. That's one of the beauties of it. It's a beautiful interface. That's it. So I've poured it on. I'll mop up the rest and off you go. Vliwazorb. And please, those who are playing with these, please keep them with their packet name. Oops. Mop up the extra. There you go. Sorry. Okay, so while these are coming around, what are these products? They're generally an interface fabric covered with cotton wool and cellulose. However, some of them, considered to be the super absorbers, contain polymer beads. These polymer beads are virtually like wetter soil. So they swell up and they lock the fluid in. So as they're coming around, you will see they've all, particularly the super absorbers that I've passed around, they've taken up the fluid and they've locked it in. So it wouldn't matter how hard you squeezed, you can't get it out. And exactly the same they use in nappies. So good question. Can we use nappies? We do encourage you not to, but I do have a slide here to talk about that. The exudate is taken up into the absorbent materials with varying degrees of retention. They're used as primary or secondary dressings on moderate to heavily exuding wounds. And the rules are you should not cut a super absorber because the polymer beads will fall into the wound. Now, we're all naughty and we all do it, but we seal the edge. And just remember, if you do cut and seal the edge, that's where the fluid's going to escape from first. You know, if it's going to be full to capacity and fluid's going to come out, it's going to come out that weak edge. And that's why the companies really do encourage you not to cut. There's no real precautions. They're generally changed in 2 to 3 days, but if there's very heavy exudate and infection, then you're probably going to change them when the antimicrobial dressing below needs a change. Or you may be changing them daily just to keep an eye on things because you're worried it's infected. The secondary dressing on these is usually some form of retention product, tape, or tubular product of some sort. Now, a few issues. In general practice, we often meet people. How many are charging for dressings? Yeah, and we're all getting forced to do that, all right? So the patients are paying some amounts, whatever. And that becomes difficult, doesn't it? So when we're in that scenario, and it is only when we're in this scenario, all right, some strategies when changing dressings daily and funds are short. I'm very big on using breast lactation pads. They are not plastic covered, they are paperback. Now, this is only in those patients I can't use the best product available, all right? So please do not walk away from here and tell the world Jan Rice uses breast lactation pads for absorbency, because we are recording it and I can play it back to you. I said, when push comes to shove and you're in a difficult scenario, okay? The other thing that's nice is makeup remover pads or even iPads, which we all have in practice. The only problem with the iPad is it does leave some fibres behind. So you do want to do good wound cleansing the next time you redo the dressing. And for those who asked the question, the worst scenario is a continence pad. And that's because continence pads are covered with plastic, and the plastic then keeps the moisture in your pad, which is, yes, that's what you want. However, the plastic allows heat to also stay in there, and once you combine moisture and heat, you get Pseudomonas. And that is the problem. Now, if you look at your, based on tissue, and you've written down the side your product, go along and see where you would use it as a primary dressing or a secondary dressing, because mostly they're used as secondary. However, they can be used as primary in some circumstances. I'm going to now pass around a product that's in a purple container. So I'm telling you all now, so when it gets to this table, we've already moved on. You wonder what this is. This product isn't really advertised as a wound dressing product, all right? But I use it in my large obese patients with very good success under breasts and under abdominal flaps, you know. It's labelled as, it will come to you in good time, so it's in a purple bag, you'll get it. It is labelled Skin Fold Moisture Management. So well worth knowing. So again, keep it next to the packet. No. Yeah. Okay. Everybody ready to move on? Next product. Next product are our film barrier products. I don't have many of these to show you. There are some on the screen. Oh, it's not open. Take those, I'll just... Oh, maybe it does come off. Yeah, it is open. So it's a spray. Probably. Okay, I was asked a question when I'm just putting these film barrier products out for you to have a look at. I've only got one brand. Are they cheaper than another brand? The answer is I can give you what I think is the cheapest, but it does depend on where you buy. So if you're buying direct from the distributor, you're going to get it at a different cost to if you're buying it through a pharmacy versus are you buying through a medical distributor? And then what medical distributor you're using. So, if, you know, I can't really tell that to you. And part of the beauty of attending a workshop is that you've actually got some work to do, all right? You need to try and find out what the varying prices are, and that's why I give you some of the other company names so that you can do a little bit of research yourself. So what are these? Most are a form of polyurethane film impregnated into a pad or a spray. There are newer histoacrylate adhesive forms available also. So there is one that's actually a glue, a human glue. It comes in, I'll go back to show you. It's called Marathon. Where's mine? So it's that one. Oops, wrong way. It's that one over there. That's actually glue, and 3M have brought out a brand new one as well, which is human glue. So we'll go back. So these seal the skin, acting as a second layer, being water repellent. They are generally applied second to third daily to weekly to protect peri-wound skin where adhesives may damage tissue or where fluid may damage tissue. They are peri-wound protectors. Obviously, the precautions the companies will say are nil, but being allergic to some of the ingredients is always relevant. And they generally require reapplication every 3 to 7 days, depending on the brand you use. The semi-permeable films, they've already started to go round because I showed them with the pad. Oh, sorry, we need to have a look at the chart for where you would use the film wipes. So are you going to use film wipes on pink epithelium? Yes, you could. To protect it, yes, you could. So you've got a brand new wound that's healed and you don't want them to rub it too much. You don't want them to have maybe urine run on it, depending on where it's located. So you might seal it off using a film barrier wipe. You certainly wouldn't use it on healthy granulation. You may not use it on hypergranulation or poor quality, but you may use it around a moist, offensive black wound. Moist, offensive. Moisture was the key. So it may be used on epithelium around a moist wound. Okay, so the sheet films, you all know these. The sheet films, take your pick. I haven't actually put the list of names because most people either use Opsite or Tegaderm. There are a lot of other brands out there. So they're a polyurethane sheet film with a tacky surface. The moisture vapour passes through the tiny pores in the sheet film into the atmosphere, and that is the key. So companies will claim these are semi-permeable, yes? How many of you have heard the term moisture vapour transmission rate, MVTR? So companies talk about the MVTR of their product. And so they'll say this is semi-permeable. Moisture will pass from underneath this sheet of film into the atmosphere. However, if the atmosphere is high humidity, will the moisture pass out into the high humidity environment? The answer is no. And therefore, you'll end up with a macerated wound. Just the same as these were tested in a laboratory in controlled environments. So if you have a resident or a patient who is working and sweating hard, and you put a film dressing on someone who's sweating hard, you are going to have sweat problems underneath the film dressing. So you must also look at where a dressing is going when it leaves your practice. What is going to happen to this body when it leaves your practice? If it's going to go and sit near a radiator or a heater, it's on a lower leg and she sits really close to the heater, your dressing will evaporate quickly. So if you put a gel on, it might be stuck next time they come to see you and you think, oh, I put a gel on, why is it stuck? What have they done to it? So if you put this film dressing as a primary or a secondary on something that has a bit of moisture and then they go and work hard or they sweat or it's a sweaty environment, you are going to get maceration. So most of us hardly use them. So the precautions are there's too much external humidity, so the permeability quoted by the maker may be varied, and do not use as a primary or secondary dressing on infected wounds. It is in their literature. They either will get changed otherwise weekly or when the dressing below requires changing. So, are you going to put a polyurethane film on epithelium? Yes, provided you've checked the environment, done all your checking. Not on healthy granulation tissue as a primary, or any of the others as a primary. So it's really on pink healed skin is about the only place as a primary. Everybody happy? Next, polyurethane foams. Oh Lord. Bag 1 and bag 2. This is just the worst scenario ever. I know, I'll get rid of the silvers if I can. I think that's polymer. I think that's it. It's just hopeless. Okay, it's a nightmare, isn't it? It really is a nightmare. They're 2 bags worth when poor Jackie's going to try and hand them out to you. Make sure you tick off on your dressings list which one you have. All right? And now we'll go through them. They are open cell hydrophilic gas and water vapour permeable polyurethane sheets, often covered with a hydrophobic sheet. So they are both hydrophilic, absorb, and hydrophobic, don't come near me. Their absorbency is a feature. Some can completely lock the fluid into the open cell spaces, and others are like a kitchen sponge. They soak up, but when you lean on them, they leak. They can be used as primary or secondary dressings for protection and absorbency. If you're using the adhesive form, you must be very careful of sensitivities. And ideally, if you are using a foam, you're changing it only once or twice a week due to cost. And that is why we often, if we've got very wet wounds, we're using super absorbers more than these. So if we look at where would you use them? Would you use them on epithelium, pink, healthy, healed tissue, or brand new, just healed? Well, you could. Specifically, you could use one of the newer silicone ones, but you're going to leave it there for a week. So now you've got to consider the environment. Is it actually going to make the wound too moist underneath this brand new skin? But yes, you could put it on an old deer's leg because you've healed it, but you don't want it to knock it, and the foam is acting as a cushioning, and the adhesive silicone foam is gentle, therefore she can have a shower. You know, you could. Would you use it on healthy granulation tissue as a primary? Yes, you could. Would you use it on poor quality as a primary? No. Hypergranulation? No. Soft fibrin slough? Yes. Tenacious thick slough? No. Moist offensive black? No. Dry black? No. And macerated? Probably you really do need to look at your super absorber. Everybody happy? Okay, I'm sorry to rush you, but we have so much to get through. Okay, the next is hydrocolloids. And they're still trying to get through the foams.
Oh, you got this?
Yeah.
Everybody probably knows Comfeel and Duoderm, okay? But there are many, just every company tries to have every generic type of product, all right? They do try to have every generic type. So pick out the one that you know. Okay, so what are they? They are a semi-permeable film coated with a flexible cross-linked adhesive mass of sodium carboxymethylcellulose, and some also contain alginate, seaweed. They form a soft gel as the cellulose absorbs wound exudate. They are known in our formulary as moisture retention dressings, and that's a clue. Moisture retention. The gel sits on the tissue and so may aid rehydration and autolytic debridement. That's what you're taught. They are aid autolysis. The precautions. Possible sensitivity to the ingredients, but more issues are around too much exudate being created, as this is a moisture retentive dressing, and they are not to be used on infected wounds. Sometimes they are changed secondarily due to the moisture effect, and sometimes we use a secondary dressing as an absorbent pad just in case they leak. I rarely use a hydrocolloid sheet in general practice anymore. How many are using them? Okay, occasionally. It's the only one. Oh, you poor dear. Right. Well, I bet you have moisture as a lot of your problems. Maceration or Okay, so using it's a very tacky substance to use on a skin tear. Very tacky. Right. So where do I use a hydrocolloid sheet in general practice? They are fantastic for cracked heels. Absolutely wonderful for cracked heels, But because it's a moisture retentive dressing, you will put it on and you will seal it all down with Meafix, and then you will tell your patient to take it off in 2 days, to wash their foot, etc., pat it all dry, and if there's still a large crack, put another one on. Otherwise, now they go to heel balm. It rehydrates that cracked keratin tissue, which is what's causing the pain, is that dry crack. So if you hydrate it, it's soft and supple, it's not hurting. But if you keep doing this, you'll macerate. Any questions? All right, so hydrocolloids on our piece of paper for tissue. Will we use a hydrocolloid on epithelium? Yes. On a healed wound, yes, you can, but you'll just need to be aware of moisture. Will you use it on healthy granulation tissue? Yes, but watch for hypergranulation. You need to write that down. I saw you watch for hypergranulation. If you're using it on granulation, you're watching for hypergranulation. So I know there's not a lot of room on your paper, but you might just put an asterisk next to it to remind you. Will you use it on poor quality granulation tissue? Poor quality, you're probably going to end up, if you put it on, with maceration and malodor. So I'd say no. Would you use it on hypergranulation? No. Would you use it on soft fibrin slough? No. Would you use it on tenacious thick slough? Well, you could, but you'd be changing it very frequently because it's going to stimulate autolysis and therefore you're going to have a lot of fluid coming off. Would you use it on smelly black? No. Would you use it on dry black? Generally, no. However, if you had someone who came in with a 10-cent piece size, full thickness burn eschar, and you say to them, I'm sorry, the principle is when you have a full thickness burn, you need to go to a acute care facility and have a skin graft, they'll go, I'm not having a skin graft for a 10-cent size wound, won't they? So you'll say, all right, we can try to manage it, but you're going to have a bad scar. All right? So what would you want to do first? You want to rehydrate your eschar so you can get it off quick. So they work very well in that scenario, rehydrating dry eschar for you to then start to get it off. Okay? But remember, you didn't need to know what you're doing. And would you use it on maceration? No. All right, next products. Hydrogels. Where are they? Hydrogels come in 2 forms. They come in a sheet form and they come in a tube form. Find your hydrogel and put a tick on your dressing list so you've covered that off. They are macropolymer gels composed of cross-linked polymer chains between 70 and 90% water, and some do contain alginate. The water rehydrates the tissue with minimal absorbency. They're soothing and they're cool. There's a hint there. How to use them? They rehydrate tissue and aid autolytic debridement. Some contain propylene glycol, and people can have sensitivities to propylene glycol. You change them daily or second daily. And often they're covered with a low adherent pad or absorbent pad. So when we have a look at our list, are we going to use a hydrogel, whether it be a sheet form or a gel, an amorphous form, on epithelium? No. Are we using it on healthy granulation tissue? In theory, no, but if that granulation tissue is painful, this is soothing. So what's red and painful that we see a lot of? Chickenpox. So yes, we do use this plain ordinary hydrogel. The most common brand sold is Solugel, the blue tube. Solugel, that's what the one the pharmacies have the most of, and they sell it. So there are scenarios, a very painful wound, and we're thinking about comfort only. As the tubes go round, you can squeeze some on and put it on your skin and see how cool and soothing it is. So we may use it for the soothing, cool effect. Would we use it on poor quality granulation tissue? Probably not. Hypergranulation, yeah, and probably not, sorry. Soft fibrin slough, possibly, so query. Tenacious thick slough, yes. Moist offensive black, maybe. Dry black, no. Macerated, no. Calcium alginates. I've got one left, have I? A foam left. Did I have a picture of calcium alginate? Yeah. Okay, so calcium alginates. The first thing to know about these products is that in the catalogue they are classified as an Exudate management product, but that is wrong. The teaching for a calcium alginate dressing now is you only use them on bleeding wounds. Okay? So don't go stuffing seaweed in holes. And I'll explain why. Well, I've already explained why. I said to you, what goes in must come out, and seaweed breaks. And you get bits left behind you can't see. So it's an anionic polysaccharide derived from seaweed composed of mannuronic and guluronic acid monomers. It swells as the polysaccharide monomers soak up the exudate, and there's a sodium-calcium ionic exchange which aids hemostasis. They're applied to bleeding wounds and may be used to manage exudate, however they break up easily, so complete removal may be difficult. Ideally, they should not be used in cavity wounds as pieces may break off and remain in the wound and difficult to see. So when to change? Well, because you're using them on a bleeding wound, you'll change them daily and hopefully the bleeding will stop soon and then you'll stop using them. So they're very short-term use. Everybody okay? All right, so let's look at our chart. Where are we going to use these products? Are we using a calcium alginate on epithelium? No. Are we using it on healthy granulation? No. You can go all the way along and say you're just using them on bleeding wounds. All right, there's not one there, but put a category for bleeding wounds. This first one was called Durafiber, and it seems to have locked the fluid exactly where the fluid was. Okay? The second one, don't do that. The second one was called something else and it wicked up a bit. See, it's climbing up. I only put in about half that. The third one was Aquacel and only held it where it's locked. And the last one I put in, and even though it did drop down, it quickly, like even if I just put that tiny bit, look at it going up. So whilst they soak up, some of them soak up slowly and gel nicely, and others soak up but still squeeze fluid out. So you have to get to know your gelling dressing, all right? Righto. So companies do all fancy tricks to show you, wicking the moisture from one to the other, great wicking ability, great gelling ability. You have to test them for yourself. So they are 100% sodium carboxymethylcellulose or cellulose ethyl sulfonate fibres. They absorb exudate into the core of the product to form a soft hydrophilic gas permeable gel that traps microorganisms and controls lateral wicking. The primary dressings they're used as primary dressings, so do not moisten them, all right? Although in the instructions, some of them say moisten, and that's for a specific wound type, all right? So on the whole, you're using them for absorbency. So no real known problems. They're generally changed second to third daily, and they're generally covered with an absorbent pad. Okay, 20 minutes. Okay, next is HydroClean Plus. Oh, hang on, gelling fibres, not on epithelium, yes on healthy granulation, maybe on poor quality granulation, not on hypergranulation, yes on soft slough, maybe on tenacious slough, not on moist offensive, not on dry black, and maybe on macerated. Just open one of those. Oh, okay. Okay. This is a little cushion pad full of polymer beads in which they have now impregnated it with polyhexamethylene biguanide, which we will talk again about in a few minutes. I don't use these in general practice very much. Why? Because you must have the size to fit the wound. You definitely cannot cut these. They come pre-impregnated. It's coming around now. Fantastic in aged care. Okay, so they are a polymer-filled sealed sac where the polymers have been preloaded with PHMB. They slowly drip the PHMB into the wound, and then the empty polymers begin to suck back the exudate and lock the bacteria within the product. Clever dressings, very good. Depending on the type that you buy, you're either going to change it second to third daily. Do not cut them. No real precautions, change second to third daily, and generally covered with a secondary absorbent pad. All right, next. Oh, hang on, where will you use it? Where do you use this product, the HydroClean? You could use it on poor quality granulation tissue. You could use it on tenacious slough, and you could use it on moist offensive black. Okay, next is the Cadaxima iodine. Only one company has this, so it's easy. It's 0.9% iodophore in a polysaccharide chain with polyethylene glycol. The beads absorb and expand to form a gel. You cover it with any form of cover the wound with any of the forms of the product. You cannot use it in people who have iodine sensitivity, Hashimoto's, thyroiditis, goiter, children, pregnant women, and you also can't, there's a maximum dose, 150 grams per week, which is a hell of a lot. So, you know, I used to say Kerry Packer's the only bloke who could afford that. When to change, second to third daily, and they're generally covered with an absorbent pad. So where are you, yes? Sorry? Because of thyroid disease again. So iodine in the thyroid gland, etc. So where are you going to use it? You could use it on poor quality granulation tissue. You could use it on soft fibrin. You could use it on tenacious thick slough, and you could use it on moist offensive black. Personally, in my practice, we use a lot of the powder because we find the powder more absorbent and cheaper. Next. I did bring marathon. Okay, so this product is known as enzyme algino gel. Comes in two forms, hydro and forte. It is an antibacterial enzyme, or two in fact, that have been embedded into hydrated alginate beads. The enzymes engulf the bacteria, and the alginate gel provides the moist environment but also does absorb some exudate. It's applied directly to the wound, or you can impregnate into saline gauze pads for larger, deeper wounds. There are no known problems as both agents are natural ingredients. It can be used daily, second daily or third daily, and it's generally covered with a non-adherent pad or a foam or even an absorbent pad, depending on the scenario. So the Flaminol Hydro is a hydrating, and the Flaminol Forte, because it's made with more manuronic acid, is a more absorbing, so a more drying up one. So in your pieces of paper, we're heading down. We could use these on poor quality granulation, soft fibrin slough, tenacious slough, and moist offensive black. There is a hydrogel out there, this one, Wound Aid Gel, that actually contains 4% melaleuca oil. So tea tree oil hydrogel. The enzymes engulf the bacteria and the alginate gel provides the moist environment and also absorbs. These can be applied directly to the wound or impregnated into saline gauze for deeper wounds. Obviously, you need to be cautious of people who have sensitivities to tea tree oil. And they can be applied daily or second daily or third daily, and generally a non-adherent pad is used. Now, I find the tea tree oil hydrogel wonderful in palliative care wounds and in some dehisced surgical wounds where the client wants to do a daily dressing. Then this is a very cost-effective product. Next, Sorbact. Sorbact. Oh, okay, it's okay. Oops. Sorbact. Oopsie daisy, going the wrong way. Sorbact is a soft rayon-like cloth that has been dipped into a solution known as DACC. DACC is a synthetically produced derivative of a naturally occurring hydrophobic fatty acid, which is also found in spider's web. Nothing like having a little bit of useless information. Most microorganisms are hydrophobic, and the product is also hydrophobic, so it attracts bacteria to itself. And once there, the bacteria are bound to the cloth, and that's why it's called an antimicrobial binding dressing. It's directly applied to the wound. The precautions are no known issues really, can be used daily, second daily or third daily, and generally covered with a non-adherent pad or foam. So we're probably using this on healthy granulation and poor quality granulation, soft fibre and slough. They're probably the three most common areas to use it on. Next is me salt. I don't have the other brand, no. You're getting your steps up today. Okay, there are two brands of hypertonic salt. There's Curity and Me Salt. So it is 15 to 20% sodium chloride in a dressing, and it can be dried or in a moist dressing. So Me Salt is the one that I use, and it's dry. The hypertonic salt has a drawing action, attracting water to itself. It's also initially it is also initially an unacceptable pH to bacteria. It's applied directly to the wound with no overlap on healthy tissue. It's not to be used on dry wounds, not to be used on viable tendon or bone. It's generally changed daily, although in some circumstances second daily. And the secondary dressing, because this is a daily dressing, is generally an inexpensive super absorbent. Now, for some people, if you're packing it into a wound, I hope I've got it here, yeah, I do the lollipop wrap again. It does come in a rope form, but it's very expensive. So I just have my square, and then I just run around and make my big long string to pack into wounds. All right, so this is great for sebaceous cyst removal. It's great for pilonidal sinuses. It's great for abscesses. Wonderful product, cheap. Me Salt. Okay, the next product is Zorflex. I don't have a piece of this product. It's activated carbon cloth that was actually developed for the military, so to line the NBC suits, because when you're in an NBC suit you sweat a lot, and this was to stop folliculitis. So the manufacturer found a use for it in medical places. So the electrostatic forces draw, trap and kill microbes. It has conductivity properties, and it has odour management properties. It's applied directly to the wound and can be cut to the size of the wound. There are no contraindications really. Ideally it stays in place for 3 to 7 days and generally absorbent. I think I've missed something. Okay. Zitaval, metronidazole gel. If we're going to use metronidazole gel in wound care, we want to use the cheapest form available. Both of these are exactly the same, Rosex gel and Zidaval vaginal gel. The cheaper one is the Zidaval. Okay, so if you have a very smelly, horrible wound that you think you have anaerobes in, this is the product to use. It's an antibiotic and an antiprotozoal. It inhibits nucleic acid synthesis by disrupting the DNA of the microbial cells. It's applied directly to the wound or mushed into wrung-out saline gauze and applied to the wound. It may cause a rash, but not usually in its topical form. It's changed daily and covered with an absorbent or superabsorbent pad. On our piece of paper here, we didn't do mesalt. So where do you use mesalt? Hypergranulation tissue and soft fibrin slough. Yeah, I know, I'm going to run out of time. And where do we use metronidazole gel? Soft fibrin slough, tenacious thick slough, and moist offensive black. Yeah, I'm sorry, but I've got 10 minutes and we want to do leg ulcers. I knew it was going to be like this. Kenacomb. We do use kenacomb. We specifically use it for vasculitic ulcers, vasculitis. It's a steroid. And so the steroid calms the inflammation down. It's very soothing for the patient. And of course it manages bacteria. So it's anti-inflammatory, antibacterial and antifungal. Why I put both types on the screen was to ask you, when you're asking a doctor to order kenacomb, please ask for the otic, not the other one, because the otic is on PBS and the other one is not. And it's expensive. So you can get 5 small 5-gram tubes in the otic on a PBS script. So that's what it contains, all right, and I said that. So resistance may occur if used for too long, so no more than 1 month continuously. It's a daily dressing and generally covered with a non-absorbent or absorbent pad. Next are the silvers. Okay, take your pick, tick which one you know on your, write down on your list which silver you've got. There are many of them. They may all vary depending on the actual product chosen, but generally they contain 1% silver ions. The silver is both antimicrobial and anti-inflammatory. It's applied directly to the wound, and Acticoat is the only one that has to be pre-moistened with I've got sterile saline, it should be sterile water. It should be moistened with sterile water. Obviously don't use them in anyone with silver sensitivities, and again it will depend on what type you're using as to how frequently you change them, but they're generally once or twice a week. And the secondary dressing depends on the particular product used. So in our sheet for the silver, it will be on poor quality granulation, soft fibrin slough and tenacious slough. Honeys, there are a stack of honeys out there. The one that I've had the best results with is Beringa Bioactive Honey. They come in tubes and they also come in sheet dressings. That's just a sheet dressing. Smell it. So where would I use honey? I generally use honey on a wound that I think is infected and has tenacious slough. And generally if I'm using the honey in the tube, I mush it into gauze, because if you put it straight on the wound, it drips off before you can get your secondary dressing on top. And generally it's done daily. So on your chart, you'd probably use it on tenacious thick slough and moist offensive black. Now, you all know Pronto San, but there are also dressings that contain PHMB. All right, so the one closest to me has a melalin-like product with PHMB in it, and the one on the other side is a foam-like product. Polyhexamine biguanide is a broad-spectrum preservative and an antimicrobial surfactant. It's a cleanser, and because of the surfactant, it aids to debris to lift off the wound. It is a 10-minute soak, and there's no need to clean off, or you just remove the soak. Only precautions are people with sensitivities to the ingredients, and it's not to be used on hyaline cartilage, and it's generally used at each dressing change. Next is Microdacin SOS. Who's using this? Okay, so this is a new kid on the block. Prontosan has had the rule of the roost for a long time, so new kid on the block, coming in cheaper than Prontosan. Amazingly enough, for those oldies in the room, it is a hypochlorous acid with sodium hypochlorite in it. Oh dear, Milton is back. Electrolyzed water. It's a 99% kill of planktonic organisms. You spray it onto gauze, and this company says about 5 minutes soak. So naturally somebody else has to come along, and now we have octenolin. Octenolin is octinidine hydrochloride. It's a cleanser surfactant, and this product can be left on the wound for 1 minute. So district nurses would rather use this than the other one. And of course, when a company comes to the country, the prices are always low until they get you used to it, and then they start to climb up. So you need to do your investigation as to which of these super cleansers, as they are all cleansers, which one you want to use in your practice. But I would strongly recommend you must have a cleanser in your practice, not just normal saline.
What about Parry foam?
Parry foam's excellent. You can use Parry foam. Odour absorbing products, there's a number on the market. Oh, I think. Oh, maybe not. Maybe I've got rid of them already. Charcoal ones. I think I've sent them around already with some other products. Don't worry. Okay, so there are, yeah, with the silver maybe. So there are odour absorbing products, all right. In my practice, see the product in the tube there? That's a company called Future Environmental Services. And Future Environmental Services has a spray, and when you spray it, it completely neutralises the odour in the room, not leaving another odour to disguise the odour, which is just, you know, it's subtle, it's very gentle. You don't have a patient walking in smelling frangipani and go, oh, that bloke must have stunk before. You know, it's very delicate. So I would recommend Future Environmental Services, or if you're using any spray, it must eliminate the spray and not replace it with another, eliminate the odour and not replace it with another. Topical negative pressures, we've already spoken of. Zinc paste bandages, we lost them, but now we've got a few back. So we've got Zipzoc, Viscopaste, and we've got Coflex. There are more coming, all right? So the L&R company have another one also coming. We're getting more zinc bandages back. Where do we use zinc bandages? In venous eczema, venous disease. Scar management, everybody wants to know about scar management products. I will tell you that they all contain silicone, and the company probably with the most evidence is the one called Strata Derm and Strata Med. So the Strata one here. Okay, so we have about 2 minutes left. So what I think I should do is I think I should show you what I put. I only added this because I suddenly thought you probably want to see some leg ulcers. So let's just fly through this, all right? And then I do have a couple of products I want to talk about. So skin tears, you all use this chart, do you not? Yeah. Okay, there's a new group out called the Ice Tap. We're not teaching it because they've got rid of the A and the B, and the majority of us like 1A, 1B, you know, 2A, 2B. So we're staying with STAR, but just know Ice Tap is around, International Skin Tear Advisory Panel. So this is a category 2A. Yes? My experience is that in category 1s, we're okay to use steri-strips in general practice because there are so few of us in general practice. You know, there's only 2 or 3 nurses. In an aged care facility, there are lots. So they all have their own method, and therefore steri-strips have been banned in aged care facilities. But in general practice, we do really well with them. But it's a matter of, I say, they come in a packet of 3 for a reason, doc. You only need 3, right? So not 100. And if everybody follows the practice, it's okay. Category 2 and category 3 may need an impregnated mesh or a foam. Venous disease. Understand the veins, people. You've got superficial, perforators and deep. You must know how these work. To have a good functioning venous system, you need all of this. You need to breathe, deep inspiration. You need to have valvular competence in both the superficial and deep systems. You need to have a good muscular lower limb system, and you need to walk properly. So your old dears that shuffle along are not using their venous pumps at all. When we look at leg ulcers, we can have venous hypertension, peripheral arterial disease, or lymphedema, or a combination of them. We do not want doctors writing down PVD anymore. We need to be very specific. Which system are you referring to? Because then you can get your recipes. Here are the characteristics of a venous leg ulcer, and you can get these when you go to the websites I've recommended for getting more information. But that's your classic lady. She has everything there. The lipodermatosclerosis, the inverted champagne bottle leg, the ulcers irregular in the lower third of the lower leg, and she's got visible varicose veins and ankle flare. Arterial, we've got a stack of problems there, and that's what they look like. Very different. And just to show you, 2 in exactly the same location, but they are different pathophysiologies. Okay? So your job is to know what it is. Most of us use tubey grip of some sort, yes? And that's often all we have. If you're using tubey grip and you think you're using it for compression, then you should be using probably 3 layers. And the 3 layers is as described there. Long one, toes to knee, then toes to 2/3 the lower leg, then toes to 1/3 the lower leg. There are short stretch bandages, which we often will use. There are multi-layer bandages, yes. And now we have Velcro wraps. Now these are, so I've got the horse just to show you, you know, we're very. Okay, so these are very, very good for those patients who will not wear compression because they can pull it up as tight as they like. Okay? To get them into compression, we have all kinds of devices available. The Easy As is a very good device. I get them to shower at night, put their good quality moisturiser on at night, and the next morning get up, put a light moisturiser on. And the reason being is that compression garments are not allowed to have any moisturiser that contains petroleum in it. So your dermis can't be used, and then you put a stocking on top. You're going to rot your stocking. What's safe when starting out? Well, 1 layer and then 2 to 3 layers, and then go into about 20 millimetres of mercury pressure. What I'm recommending now is IPC, and my patients are getting the intermittent pneumatic compression. There's the device, and the reason that my patients are getting it is because it's $40 a week to buy, or to rent rather, and then when you hit a point where you go, okay, this is now viable, and so the man says, you've spent this much money on renting, why don't you spend another $600 and the machine's yours? Now my patients love this. They put it on while watching Days of Their Lives. They don't want to wear those stockings, but this, so 3 times a day for 20 to 40 minutes a day, it pumps the fluid out. They're wonderful. So you want to learn about these devices for those naughty patients. Also can be used for people who have arterial disease with dependent edema. Okay, so learn more. Best practice guidelines, lots of them, so therefore I've left you all these resources to go to. Our Facebook page down the bottom has a question every week posted on Facebook, and then at the end of the week gives you the answer and the reference paper to read. That's CPD, so if you keep a journal of attending all these Facebook questions, you will build up your CPD. All right, it's very, very good. They're very, very good clinicians there. Now on the table I have a couple of things I have not mentioned. So if I'm running out of time, I have one product I want to talk about. I want to tell you about this product, all right? It's called Mundicare Skin Relief Powder. So a few weeks ago I had a patient come in and the smell was horrendous, and it was coming from him dripping into his shoe. So you've all had that problem where you put the fanciest dressings on, then you've got to put that disgusting foot back into the shoe. So I sprinkled this powder in, so you can start taking it around. And because it's lunchtime, that's why I've left it. I want you to do this. Feel your hands together. So make sure it goes around fast. And then do this. There you go. Okay.
It's the test.
And then do this.
The quicker you do it, the quicker you get to
And then feel your hands. It's super drying. This is fantastic for intertrigo, groins. It's tea tree oil talcum powder. Smell.
Yeah, nice.
So I've used this in shoes to knock off the smell, and it works beautifully because it's an antifungal. So I strongly recommend that product for you to have a look at, all right? And the only other product I would say is this one. Do you all use Tubular Plus? Do you all use something that looks like an Explorer sock on a roll? Yeah, okay, so we don't need to talk about that. Okay. Obviously, I'm running this conference, so anybody from Victoria? Okay, so this is in Bendigo in October, and one whole day of plenary, all on wounds, got a dermatologist, an orthopaedic surgeon, a vascular surgeon, really good, and then the next day's workshops again. Okay, so big workshop. Let's just make sure we covered off very quickly. So leg ulcers, 3 most common types: venous, 70%, arterial, 10%, mixed, 10%, and weird ones like the Barili, they equal the 2%, okay? So Barili, high suspicion that they've been to an area that is endemic. So Victoria, sadly, okay? So the beaches of Victoria. So if you're suspicious, what do you have to do? A PCR. Diagnosing them, started as an insect bite and then ulcerated rapidly, painful, and undermined edge is the classic. Now sadly there are some that are not undermined, but the majority undermined edge. So painful, undermined edge. Do a PCR. If the PCR comes back negative, the guys tell me repeat in 2 weeks' time. You might have just got it too early. I've mentioned Future, did not discuss burns, but in general practice, the dressing product that I use in burns is Burn Aid gel. So when they come in, we use Burn Aid to settle them down, and then we do the examination and assessment, and they go home. If there are a superficial partial thickness, they go home doing a daily Flaminel Fort dressing. We use Flaminel in general practice more than silver because it's cheaper. We want the boys, my boys are Holmes Glen TAFE College boys, they oxyacetylene themselves. So I want them to have a shower every day. I want them to be clean. Okay, so you've got to look at your client group. Those of you who are using silver on burns and having success, that's fine. Different client group. So we use the Burn Aid to calm it down because it's cold when you put it on. And then we use the Flaminel Fort daily. And they have to change their dressing every day and come to us twice a week for maintenance checking. So done that. Debriding and slough, I've done a bit of that. All right. So the cleansing solutions, soaking, and then break your forceps in half, and you've got a forceps with teeth on it, and now start to scratch. Then grab another piece of dry gauze and mop up the muck. All right, that's really what you've got tools to do. There are little products called Deborah Soft out there. There's sticks, lollipop sticks, and other Enyo for the wound care. Enyo pads for the wound care. All right, that's what I call them, all right? The problem is $20. So back to the forceps for me. And I find that your stitch cutter is really good because it's got a round head, so you can kind of get in and flick stuff up. But just remember, as I tell everybody, your stitch cutter is actually sharper than my scalpel. They are really sharp stitch cutters. So be careful with it. If you feel confident to do it and you're trained and you know your anatomy, then yes, you can cut. Obviously, making sure your patient is all registered nurses, as I'm assuming, registered nurses, all right? But it's all about your bosses and what the employer says. APRA says if you feel it's within your scope of practice. So if you've done some anatomy, etc., and you feel, you know, for me, I was trained by doctors, so I'm forever cutting, all right? Right, hypergranulation, we said me-salt. Righto, 2 minutes for questions. Yes?
There used to be Monash used to do a debriding type.
Yes, Monash still does.
They still do.
Oh, hang on, no, La Trobe does. Monash, La Trobe. La Trobe University has a module, online module, and then you do an attendance to a 3-hour night class. And myself and Melinda, we run debridement programs too. You can. So my name is on the front of your handout. We run debridement days. Okay, next question.
I'm still concerned about the betadine.
Okay, so I didn't do betadine. I'm the queen of betadine and I didn't mention betadine. Okay, anyone with staph? Anyone with folliculitis? Anyone with frequent boils? Anyone who's yucky, got scaly, disgusting, horrible lower legs? Anyone who's got under here and here? They all, and pilonidal sinus. They all have betadine surgical scrub washing. Okay, so the pilonidal sinus is from the waist down, under the boobs obviously. The leg is just the leg, wherever you're worried about. Betadine surgical scrub. Blue bottle. It's betadine soap, it's what the surgeons wash their hands with. Rinse off. Pat dry, pick off your scaly, horrible skin. If it's under here, then you might use that talcum powder. And then you might use the super absorbent pad that went round. Okay, that would work. All right. If it's that horrible, disgusting leg with all the scale and you've picked all the scale off, then you'd use iodis. You'd moisturise the leg. Good quality moisturiser like Dermavine or QV Intensive. And then you would sprinkle the iodosil powder as your first form on your ulcers or flaminal or sore-backed and an absorbent pad. Now, where do I use just neat betadine in wound care? Only when I have the black toes, the black areas like I showed you at the beginning. So the black, they come out of hospital because someone tucked the sheets in too tight. Now they've got black tips of toes. Betadine, betadine, betadine. Between the toes when it's moist, betadine wrapped round between the toes and changed twice a day. Or a palliative wound. That's where I use betadine wound care. The boys, when their pilonidal sinus is healed, it's mostly boys, when their pilonidal sinus is healed, they carry in their wallet, next to the condom, they carry a little thing that looks just like a condom wrapper. So the little wipe, betadine wipe, and I tell them when they go to the bathroom to wipe the crack. Because you want to stop the sweat running down and getting in here with the hairs and then the shear and friction and the bugs take off. Yes?
So what about patients that can't, that are unable to change it twice daily? You're waiting for them to get into the wound care clinic to look at their black toes.
Okay, so once a day would be okay. So on the black toes, it's only once a day. It's between the toes that's twice a day. But black toes, black bits, it's just paint it once a day. Yes? Okay, so I have a recipe and I'm pretty good at the pilonidals. I get them when they're 18 months non-healed and we have a standard in our clinic that we can heal them in 5 weeks. So, if I may indulge, but you are going to bite into your lunch hour. Okay, firstly, no smoking. So when they get to see me and they've had it for 18 months, I say, I've got rules and you either follow my rules or you can leave now. That's the first thing I say, okay? So no smoking. Now when they do smoke, I say, okay, how many? And could you please get down 2 by next week? So, you know. Now, fresh fruit and vegetables, they must have vitamin C. All right, so the boys, terrible at eating, so I get them to call into the health food shop on the way home, buy a bottle of vitamin C and pop them. And they're usually good at taking the tablets. So vitamin C you need, All right, now clean the crack, betadine surgical scrub. Depending on what tissue I've got in there, if it's soft jelly stuff, then it's me salt. But if it's red, but I still think there are bugs there, it's saw-backed. On top, I then roll gauze. So this is a really good demo for you. So if you have a piece of, I could wipe my nose with it first, piece of 10 by 10 gauze, most of you, when you want to put pressure on, you fold, right? So just feel that, tell me how hard it is. Oh, righto, we'll just wait for this girl. Righto, now. But if you roll gauze, and now tell me how hard that is. Right. So rolled gauze gives you more pressure than folded gauze. So you roll it up, it actually looks like a tampon, and in fact sometimes I have used a tampon. Okay, so you put that on top of your me salt in the crack. And what it's going to do is catch the exudate that runs down here. All right? And it's going to put pressure in the crack so your dressing's right down in where you want it. Next, brand new what do you call these things? Jocks. Brand new jocks, not boxes. Brand new jocks. Next, your footy shorts or your skins or lycra shorts. And the rationale is that you stop shear and friction, because when we walk, one buttock goes up and one goes down. All right? So I need to keep those two together to stop shear and friction. And that's the recipe, and it works. Every day, twice a day if they want to, if they're doing something. So I just had a chef, an Indian chef recently, and he stunk of fat, like his clothes were just awful. And I said, I think you might need to do your dressing twice a day. Just because, you know, it must get really hot in the kitchen and what have you. So and he did. It was fine. He healed in 3 weeks, and he'd had it for 7 months before I got to see him. So the recipe works, but you've got to be very strong. The other thing is that they get depressed with this. So, you know, my army boys would say, can I do gym work? And I go, no, but you can. So I tell everybody, especially the young boy, you can do all the weights, you can do all the upper, and you can do straight leg raises. You just can't do that. And I also teach them how to sit down. So I actually demonstrate, you know, and I say, you know, you boys sit down like this, right? Well, now you're going to put your legs together and you're going to go sideways and then like this. So demonstrate all of that. And they can run too. They can. Some of them, I've got footballers, they have to run. They don't like anyone knowing they've got an extra hole in their bum. So it's very private. So they just wear their what do you call those long things? Tracksuit pants. They've got their skins on, they've got everything on, they have their tracky pants. And with your tracky pants, your knees together, you can actually run and know, because tracky pants are loose, it's going to drip, because tracky pants are loose, no one actually knows you've got your knees together. So you can actually run like this, and no one knows you've got your knees together. All right? So I let them do what they can, but they can't do this. So no lunging. All right? Come on, let's go to lunch. You've had it.
Just one moment.
I know you've just clapped, but I've actually got a gift. We've got a massive Hague's chocolate frog for Jan. I think you've probably had information overload, but Jan has given you a lot of good resources to go away with. So I think give her a big round of applause.
Wow.